Welcome and thank you for joining us for the second webinar hosted by the Wisconsin Immigrant and Refugee Mental Health Network. My name is Brianna Gooden. I'm a graduate student at UW-Milwaukee Zilber School of Public Health, interning with the network this summer. Our guest speaker today is Dr. Fred Coleman. He's a practicing psychiatrist and faculty member at UW-Madison with over 30 years of experience working with the Hmong and Cambodian populations. And today, Dr. Coleman will be speaking on unlocking global mental health. A few housekeeping reminders before we start for anyone joining us later for the webinar. There's time allotted at the end of the talk for questions for the live audience as well as webinar participants. For webinar participants, please ask all your questions in the chat box and we will answer them live. This webinar is also being archived on the YouTube channel listed under the Wisconsin Immigrant and Refugee Mental Health Network. So please visit the channel to view our past webinars and subscribe for any updates. Thank you.
So today, Dr. Sebastian and I, Dr. Coleman, will be reviewing the background to the call to action that was issued from a joint meeting of representatives from 3 countries in Africa and the mental health community in Wisconsin. A call to action regarding mental health. So to begin the background, I'm going to ask my colleague, Dr. Sebastian, to give the brief history of the East African Psychology Conference.
As most of you are aware, and those that are listening to us, the issue of mental health has both local significance and global significance as well. And so you may wonder how Milwaukee and this clinic, Sebastian Psychology Practice, and our local partners, why would we be interested and concerned about other parts of the world? So the connection is, fortunately, being an immigrant, and my wife and I are both immigrants and very much focused on understanding how to do the work here well, but also being aware that in our native country, Uganda, there's a high experience of high stigma towards mental health, and very much little understanding on the development between mental health and health in general. So because of that need, for many, many years, we are involved in providing public education, case consultation, visiting universities, visiting schools, on invitation to talk about why psychology is important. And so fast forwarding to about 2012, we had formed 3 years before a non-profit and had a couple of people that are interested locally here to help us continue the work of lowering stigma towards mental health here within our Metro Milwaukee area, but also have the same conversation in East Africa. So in 2012, we had our first Uganda National Conference. That conference was intended to be not only for folks who are in psychiatry, in medicine, in the areas of psychological support, but to have it interdisciplinary and to go across sectors, because we knew that only by doing that could we bring the awareness of mental health to the street, the local person. So we had psychiatrists, physicians, primary care providers, administrators in schools, social workers, both in hospitals and in the inpatient hospital of the nation, who are very intentional on including traditional healers. Traditional healers, both in terms of herbalists and spiritual healers, are such a first line of defense for medical issues that are difficult to understand, because the beliefs are, and still very much still continue up to this day, that the causes of mental health challenges are not very well understood. And so the connection between maybe a spiritual origin, maybe some kind of unsettled business with the world of traditional ancestors is not understood very well. Traditional healers would come into that space, try to explain it. And so fast forwarding now to 2019, that conference that started in 2012 has resulted in a conference in 2014, 2017, 2018, 2019. Not only addressing now just Uganda, but for East Africa in general, because the issues that were coming forward were very much similar to those countries. And so up to in this June, from June 15th through June 28th, we hosted 3 professionals. One, Dr. Hafsa Bukwata, who is the chair of the mental health unit within the Ministry of Health in Uganda, joined by Dr. Bashir Okra from Ethiopia and Somaliland, and another psychiatrist, Dr. Tunde. They came to join us to provide an opportunity whereby they could each talk about their practice experience, their community and national programs on mental health delivery and recovery, and then listen to us on the ground in how we are delivering services and delivering care to see how we compare notes. So they spent time here in Metro Milwaukee, about 3 days, and then from June 19th through the June 28th, with the help of Dr. Coleman and other departments at the Medical College of Wisconsin, School of Nursing there, the African Affairs Department, Global Health Institute, all of us working together to host this dialogue and have this important discussion. And so the decision was made right from as we're preparing this, that because this is such a big issue, not just for Uganda, not just for Somalia or Ethiopia or Africa, but a global issue, as we so very well understand from the WHO and the World Federation on Mental Health, that we needed to have expand this discussion and stimulate communities in the kitchen table format to talk about why mental health is important, and hence the call for call to action.
So let me pick up with some of the things that happened during that time. The 3 visitors from Africa come from settings in which a large part of the psychiatric care for those most ill are in hospital settings, and they're looking to develop community practice settings. On the other hand, they had a lot to teach us about coordination with communities. So I'd like to run through some of the learnings that we shared during the 10 or 12 days before we wrote and issued the call to action. So from Dr. Bashir in Somaliland, we began with the image of chains, because at the time he arrived in Somaliland, all of the then existing hospitals had all inpatients, not just those who were dangerous, chained. And people were chained at home. And when he arrived to take over a new hospital, we told them there will be no chains in the hospital, and there will be no locked doors. The immediate response he got was, that won't work. The patients will hurt themselves, the staff will get hurt, no one will want to work for you, and it will not go well. In fact, no one has gotten hurt, no patient, no staff. The families are delighted, and they have moved towards ending the chaining of people in the community. And this first step of breaking the chain of chains got us thinking. You'll hear later that we moved to the metaphor of unlocking doors. You'll understand some of why. A second thing he shared with us was that because of the lack of resources, we tend to think of ourselves and complain sometimes that we don't have enough resources. In Somaliland, they have 4.5 million people, and they have 4 psychiatrists, and no psychologists, and no social workers, and some general medical nurses who are trained in mental health. And they don't have a lot of resources. But for the most ill, they provide completely free hospital care and completely free medications. Because they formed an agreement and a shared working with the community. The community is 95 to 98% Muslim. And they formed an early partnership with the imams, with the mosques. And in terms of the expected Islamic tradition charitable giving, everybody who can afford it gives 10 cents a week or more if they can. That money has been enough to build the hospital, provide free care, and provide free medications. So this idea of true community partnership, and particularly with the religious community, broke a barrier that had been there between the understandings in the mental health community and the religious community. They also have a large number of traditional spiritual healers. This is not Islamic, this is part of a much earlier, many centuries tradition. What they found was it took an average of 8 years before someone got to psychiatric care, during which time they were getting repetitive spiritual healing, which was helping some people for some mental health problems, but was not helping with psychoses. And Dr. Bashir went out and formally established referral relationships with the spiritual healers. He said, do you have people who, despite all you do, don't get better? He said, we do it. We don't know what to do with it. He said, send them to me. I will refer them back to you in the community. The agreement is you won't recommend they or their families take them off their medicine, but you will come back and do things that make them feel part of the community that they're part of. So now there is active referral between the traditional healers to Dr. Bashir in the hospital, and from the hospital back to the spiritual healers. There is a regular working back and forth between Dr. Bashir and the mosques. So there is an incredibly active community referral network. Dr. Hafsa Lukwada, Acting Minister of Mental Health and Substance Abuse Services in Uganda, is facing a situation of one of the 2 countries with the highest rates of alcohol and drug use in Africa, Uganda and South Africa. It's a very serious and culturally devastating problem. It's a multicultural society. Christian, split between Catholic and more conservative evangelical Christians as the 2 largest Christian bodies, and a smaller percentage of Muslims, as well as a variety of people who do traditional spirituality. There is a new mental health law passed, the first one in decades. She is going to be in charge of implementing this. But they are already trying to act in small ways. So one of the problems with alcohol is that beyond all the things that you can see on the shelves here, bottles of every kind of alcohol you can imagine, they have a thing called sachets, little squeezies, sort of the size of one of those airplane liquor bottles, but it's a kind of thing, and don't let this worry you unless you're taking transportation in the city. The little motorcycles that you hop on the back of to ride from one place to another, the drivers can drink as they travel. The youth in the schools can have the little sachets and easily access alcohol. So one of the first policy implementations was to ban these super small containers. It doesn't stop people from drinking, but it impedes the ease of use, particularly for youth and in a variety of public places. So part of what she is looking at are other ways that you can move for early and slower changes to implement policy that can affect major mental health issues. Dr. Tunde Ojo Massey Ferguson, while he is head of the Department of Psychiatry and head of psychiatry at a large hospital in Abuja, a town of 4 million, the capital, in Nigeria, 200 million people, and about 200 psychiatrists, also about 1 per million. And I didn't mention in Uganda, it's about 1 per million. They're really looking at implementing community-based treatment. So he has gone out of the country to study global mental health and come here because he is collecting a variety of community-based interventions and plans to make cultural adaptations. So he really put forward to us the notion, don't just look at home, go wherever you can and find ways that people are dealing with the problem you face, in this case, community services. Find the best practices and then adapt them to your culture. As we looked at issues here in Wisconsin, our group identified a number of concerns. Now, by this time in the week, we were talking about moving on in images. So the image we had moved to was the locked door, or the door that is shut. It is shut, it holds a family inside so they get no help. Mental health problems hidden away. The door to a clinic that only some people are allowed into. We have far fewer seriously mentally ill people in hospitals, 30, 40 years in this country. How did we accomplish that? Positive side, community programs. Negative side, a dramatically increased jail and prison population. So we shifted people from treatment to incarceration. And we shifted people more frequently based upon minority status, color of skin, language, culture. And so our prison systems are breaking down under the strain of people who are put there because of mental illnesses and some violation of law because adequate services aren't available. It's the promise that when we close the hospitals, we would have adequate community mental health has never been funded and never met. So we saw this, a set of doors that were closed in this country. Issues of economics, race, incarceration, and access. On the positive side, we talked about forms of community intervention. The original PACT program of assertive community treatment, which has grown into the CSP program. Teams that actively go out in the community, go wherever a person is, provide medication, provide support with housing, provide support with all necessities of life. We talked about clubhouses and rehabilitation for work. Grand Avenue Clubhouse in Milwaukee, Yahara House in Madison. We talked about trying to build adequate crisis intervention services so whenever police are called to a situation with someone who's mentally ill, there will be trained mental health professionals either embedded in the police force or on immediate call so that people are diverted to treatment, not to incarceration. We talked about community embedded programs. The Cambodian trauma treatment model, which is embedded in the Cambodian Buddhist temple in Oregon, and the Hmong family treatment model, which is embedded in localized community treatment in one community. So instead of hospital or clinic, both of which present closed doors to the person in the minority community who doesn't speak the language, who finds the treatment offered culturally inappropriate, who finds no one who can speak to them. To have community embedded treatment is to open the door. So this is the background that leads to the call to action that we're going to share with you. Would people like to read aloud for us? You each have one. What we'll do is we'll start to my right. We'll ask you to read first paragraph, the call to action, and then you may pass it to whoever else in the circle you like.
Unlawful mental health care, a call to action. There is no health without mental health. June 27, 2019, Madison, Wisconsin. All families need welcoming access to quality mental health care and psychosocial support at all times. Every family faces challenges related to untreated mental illness and the increased presence of alcohol and drugs in our communities. Around the world, family members are impacted by traumatic life events experienced by their loved ones, including stigma, violence, social and economic disparities, the impacts of mass incarceration, complex emergencies, war, and environmental instability.
This need is universal, and effective strategies for health system and the community-based preventions and care are known and can be made available. Yet families in need of this support are facing increasing rates of depression and suicide. Both adults and their children, they face challenges and injustice related to people living with mental illness or addictions first they are the diploma of custody and unjusted incarceration.
We can, should, and must help all families to live and prosper by unlocking mental health care. We call on local and global leaders in government, social institutions, religious organizations, development organizations, and caring professions. We ask them to work with communities and individuals, families, and caregivers to provide access to care that is client-led, community-engaged, compassionate, comprehensive, and culturally relevant.
Unlocking mental health care puts a stop to shackling, imprisonment, separation, and exclusion, and replaces these inhumane responses with effective care and respect for human rights and personal dignity. There is no health without mental health.
We would ask anyone who views this webinar in the future to read through this document, which will also be available on the website, and consider signing on as a support, because the more people who choose to share this call of action by signing it or by sharing it with others, the more we grow a movement towards more humane care. So what we're going to do is now take the discussion in the direction of why do we say there cannot be health without mental health? One of the things we know from the World Health Organization study of countries across the world, from the developed world to the three-quarters world, is the first effort in public health is to treat infectious diseases. Infectious communicable diseases have the single biggest load of morbidity and mortality. The second intervention needs to be with maternal and neonatal deaths. This is the second greatest cause of loss of life and productive life. But when you look at disability adjusted life years, DALY, D-A-L-Y, acronym, the third most powerful loss of productive citizens in all countries in the world come from the mental illnesses. They strike early in life, whether they're psychoses, depressions, or anxiety disorders, or substance use disorders. And they can affect people through their lifetimes. The intersection of mental illness and AODA, alcohol or drug abuse, intersect with the third part of the triangle of trauma, of the types listed in the call to action. These are both huge in terms of the human suffering, and they are huge in terms of personal, family, and country economic productivity. And so when we talk about health of a person, a family, a people, country, there is no health without mental health.
And on that piece, for those of you that may have time to look this up, the World Federation on Mental Health first came up with a statement, eventually the WHO adopted it. There's no health without mental health. And indeed, if you reverse that, there's no mental health without good health. And so as you think through this, and this makes me think and appreciate my friend Dr. Timothy Erlinger's program at MSP at TWM, Milwaukee, that looks at complex systems that are, whichever way you look at this, if you're going to look at wellness, it has to come from several angles. Some of the typical models we think about the bio, psycho, social, spiritual models. When we think about health, the bio is going to look at the physical health. The social is going to look at our social beings, social entities, with cultures that are distinguished and create who we are. The psychological goes to our mental hygiene, which is so critical, and eventually will take time to challenge us that if I was to be in an elevator and I had 3 minutes to talk to an audience, and that audience could be different ages, from maybe a first grader to somebody in their 80s, 90s. That why is mental health? Why is it important? Why do we have psychological health and hygiene? These are crucial issues. So the spiritual component in that dilemma again goes to understanding that we are all, because of our culture, connected somewhere in understanding spirituality, not only from the faith-based point of view, but as spiritual entities. What those systems mean. And so as we go through this, we'll be invited to understand that you can look at in a call for action the naming of the different pieces that bring together what it means to deliver a good service, not just one sector, but several of them. So we look at this from a multi perspective, looking at an enormous problem, requiring systems to work with and along with each other for a good product. So virtually, as we go through this dialogue, we would like to give us some feedback too on what this means to all of us.
So one of the documents you have that we won't go through in detail today is the Mental Health Action Plan from December 3rd, 4th, 2004 in Rome. And what needs to be done by ministries of health, the financing of mental health care across the world, having mental health services be science-based, building ongoing education in the field, coordinating international agencies, understanding the linkages to economic development, paying serious attention to human rights, and evaluating the work that is done so there is growth and change in an ethical and effective manner. So we ask you in your own time to review that.
The Mental Health Action Plan was really developed as part of the conscious effort made by the team at Harvard Medical School. It was now known as the Harvard Program on Refugee Trauma, a very well-known program led by Dr. Richard Molika and his colleagues, a period now exceeding for 40 years. So they wanted to understand what is the impact of war. Besides the physical injuries, what does it do to the mind? So that research not only led to improvements and advice to the World Health Organization and the UN in caring for refugees, in making sure that when people have fled war, and whether they're living close to within their home, in what are called internally displaced residents, or outside their country, what is essential to keep them safe, to keep them healthy, and begin allowing them a chance to recover. And so they figured out that it goes beyond physical safety. And I need your help to remember this. There's the 5 H's. You look at habitat. Okay, that if somebody fleeing war and displacement, and here for our local communities in the urban area, you can also think about displacement in general. Habitat means housing. Is it safe? Is it dignified? Is it stable? And as communities get better and more stable, it's important to move them in those spaces. When folks are fleeing war, how long do you keep them in that transitional space? The shorter, the better, so that they can move to more stable, permanent housing and hopefully better hygiene. The advanced research that is moving forward now has now come to the understanding of defining home in what now Dr. Morika and his team have established as the HEART model, HEART, where they expand that concept of habitat, home. What what does home mean to all of us? What does it mean to a refugee from Syria who has fled to Milwaukee? And after 10 years from now, how is their habitat? How is Milwaukee becoming a new home for them? What kind of an environment have we created for them to continue healing safely and advance with their life? What kind of combination of art, music, culture, and other ways of expressing themselves are we allowing them to utilize so life can be meaningful as they become more embedded into the community? So here, the issue of culture comes up, where through language, through cuisine, through music, through poetry, and other forms of self-expression becomes so critical. And then, again, going back to the 5 H's, we go to the issue of the human rights. Wars, unfortunately, are human-made in most circumstances. Intentional violations of, they violate human rights. And as they violate human rights, they create and they amplify humiliation. And as they amplify humiliation, they take away the personhood of who people are. And therefore, psychologically, people being killed use terms like collateral damage. It's not human murder, but collateral damage. Because once we call it collateral, we're removing human piece. We have dehumanized already, and therefore it gets easier for abuse. And so this team emphasized eventually the WHO embodied in terms of legal expectation about human rights, that those are crucial. The other 3rd H would be health promotion, in the sense that when people's lives have been disrupted and they're surviving just day to day, the last thing they think about is hygiene, which is basic for health. The circumstances of their living, again, going back to habitat, are not promoting hygiene. Most refugee camps are the opposite to really being hygienic. And yet, even in that condition, the expectation is, in limited circumstances and conditions, how do you establish a healthy enough habitat for people to live in hygienic ways, but they continue to advance that? So, an example of improvement in that, on that concept on hygiene, is the example that Harvard promotes now under the HEART model, that you can improve the environment by promoting a built environment. Move from tattered, torn tents or worse, and have structures that are put up temporarily but more humane, have better hygiene. In fact, the program, an example in Palestine, where you have kids using plastic materials, build a school on a very cheap cost. And when you look at that picture and compare to a typical refugee camp as it looks, and you look at that school, see that the environment has changed. Now, the political condition on being a refugee may not have changed, but within that condition of managed behavior in a small scale, there is some control. So we want to emphasize again that if health can be promoted, it has to begin with good hygiene, but also an emphasis on self-care, understanding that if somebody is not well, somebody is anxious, somebody has depression, somebody has PTSD, these psychological conditions, how can we address them, but at the same time address physical well-being?
It becomes a 5th H, or healing, and putting that within some things that have developed in this country and elsewhere, the recovery model, that healing or self-care, healing that is empowered by the person themselves, becomes a very important component. I want to broaden a little beyond the background that was given for the Harvard project, which grew out of looking at people from war trauma what was the International Association for the Study of Refugees became some years back the International Association for the Study of Forced Migration. So now addresses three prongs. One, when war, external, between countries, internal, civil war, creates one set of people who are forced to migrate, again, internally or externally. But the second area of forced migration is economic. If there is no possibility for you to support your family, you cannot earn money, you cannot raise food, you cannot find housing. The economics of where you are do not allow you and your family to live. You are forced to migrate. And this is equally important to look at. So leg one, war, leg two, economic, and leg three, climate. Increasingly, the waves of refugees / immigrants, individuals who are forced to migrate by conditions that are prohibited continuing to live where they've been, is growing, and by 2050 will probably be the single largest cause of forced migration. So we need to take seriously that all of these are driving unknown before this time wave of human movement in the world with an impact on human mental health. So let's take that and shift, because part of the words we've been using are mental illness. And mental illness is a deficit model. It implies something is wrong, which is true. We've tried to broaden the scope so it's not always something is wrong with you or me, but maybe in many ways. But we always want to balance it with models of well-being and resilience. And so one of the things we want to talk about now, I'm going to ask you to think about this for a moment or two. If you had 3 minutes to do the elevator presentation, there's some group of people in the elevator with you, and somehow you're chatting with someone, and you mention the notion of psychological well-being, and you're asked, what do you mean by psychological well-being? What would you say in 1 or 2 minutes of what that is and why it's important? A moment for reflection. We're not going to ask any of you to do the full 3 minutes, but what we're going to do is go around and ask you to give a sentence that would be part of your presentation about why one should talk not just about mental illness, mental disease, mental defect, mental problems, but why one should talk about psychological well-being and resilience. Marianne, you get to go first because you're the Sebastian. Just good fortune.
Well, I wrote down 2 ideas, and I'm not sure that I understood what I was supposed to do accurately. But the first thing that I wrote down was the ability to feel pleasure, joy, and happiness. And the second idea was the ability to express yourself without fear of stigma or discrimination.
I like in mental health per se when they talk about the capacity to live, love, and laugh. So you're happy with your relationships to your friends and family, happy with your relationships at work, your capacity to work, and you're happy moving through your daily life.
I think, like Dr. Coleman mentioned, by looking not just at mental illness that something is wrong, but rather focusing on what can we do for betterment? What can we use to work toward this wellness? So viewing it more of a positive light, that there is room for improvement, there is a chance at bettering yourself and working through this, rather than just seeing it as that you have this problem.
For me, as I see it, if you can do anything else, you really have to focus on who you are, know who you are. You can do anything else, or before anybody can help you. For me, that's a critical part.
I wrote self-care activities promoting health, resilience, and value-based decision-making or choices, despite or in conjunction with your previous experiences or current challenges.
So I wrote two ideas. The first one is that to function normally and gladly throughout your days, and the other one is to be able to feel appreciation toward yourself and other people around you.
So I thought the ability to navigate psychologically and emotionally any internal or external barriers to move closer to your personal goals.
What I wrote down is the happy, peaceful, and the feeling that all your personal needs are met in all areas, important areas of your life.
I use an image often in teaching of the three legs that support the stool of life. First is community, to be part of a larger whole of people who are connected and related to each other. This is from family up to larger community. The second is structure to one's life. This is work in the whole range of world of work, from a workplace to producing food to managing a household, but a structure to the day that there are things that you do, give a rhythm and routine. And third, meaning, that there is that which gives meaning and purpose to you as a being in this world. This may be elements that are personal, cultural, spiritual, and religious. So community, structure, and meaning.
It's amazing what are these different perspectives really come up to. For me, I was thinking my friend here, Dr. Mary, about the American dream, the pursuit of liberty.
Life, liberty, and pursuit.
Yeah, life, liberty, and pursuit of happiness. It just captures that so much in very simple terms, but yet they mean so much. And I definitely also reference the role of culture and how culture becomes a perspective within which all of those are formulated. You know, liberty, pursuit, happiness, what that all mean, and the impact of action, especially intentional, purposeful action, and the privilege to be able to have that. That's also such an important issue. Our friends back here, finally, your buddies there. I'm going to ask you a bit first.
Shadow, what do you think? Something to add?
Shadow says someone to hold me.
Yeah, having a pet.
Right. Something to eat.
Yeah. Something to relieve himself on.
The meaning of basic human needs.
Basic needs, yep.
And animal needs. Shadow, you did a wonderful job. So part of what we've done is just take little pieces to talk about what this might be, to talk about human well-being as part of the effort that we're asking about a call to action. But now I'm going to take you to the obstacles portion, because as we met with our guests from Africa and exchanged views from the 4 countries about things that we were doing, we ended up with this image of unlocking doors, opening doors. So since we have a room of clinicians, I'm going to ask you for a different reflection. think of someone you are working with right now where a closed or locked door, literally or metaphorically, stands between them and some of these things that we just listed that are necessary for well-being. What are doors blocking someone you're working with from accessing these critical needs? What's the door and what would it take to open it? And we'll go around the circle a second time. Talk about the door metaphor for obstacles and how to unlock or open the doors.
Oh, we do have a response here from Dr. Ellinger. He said, my response to the question would have been that we are all parts of humanity on a journey to make sense out of our experiences with the focus on the common challenge.
Thank you, Tim. Okay, just to break it up a little, we'll go the opposite way around the circle. A client you're working with, a literal or metaphorical door that is closed or locked that prevents their access to one of these human needs, and the way that that door might be opened.
Trauma.
Hidden trauma.
And through effective treatment.
So we know that trauma is known and unknown, that it has an enormous toll on people, that it weighs on people, and when not recognized, not affirmed as real, and not effectively treated, it closes doors to all kinds of possibilities.
Yeah, personally, right now, considering the client that I'm working with, especially the refugees, like this morning I was visiting family clients from Congo, Rwanda. But what I see as the right now unlocked doors, okay, the language barrier, even in getting to know the system as it is. Okay, but also again, I want also to expand it to the other refugee crimes that I'm working with, who are now so much concerned about even without being able to make it to get the U.S. citizenship, okay, the migration kind of paperwork that they need. So how do I maintain my status? So there's that kind of constant fear. So so unlocking, helping them to unlock that, move on. So there is constant stress and anxiety.
So finding the necessary services to open the door to being documented, to having papers. One of the things we've noticed in the Hmong project that we tracked for years was people's general level of function, level of symptoms, and without exception, there is a dramatic uptick in level of function when a person receives their citizenship. And it makes it clear that didn't heal any trauma. It didn't take away economic problems. It didn't solve many of the other problems. To become a person with papers who has a right to be safety significantly increases well-being. A door that is closed or locked,
I have a refugee client who has had incredible trauma, but she also has a condition that leaves her in intense physical pain, sometimes intractable pain. And she is not able to access any reasonable pain treatment at this point because of the community perceptions around and sort of the pullback in hysteria that's going on. So it's preventing her from continuing in her healing mentally because that is.
How might that closed door be
advocacy and education for the, I think, the decision makers, including professional associations, the media, and I think also with lawmakers as well.
It's important. We are not having anything novel in this current 2010 to 20 statement that we have a narcotic epidemic. One of the previous drug epidemics in this country was in the 1960s. And it was perceived as a massive problem that needed to be dealt with by criminalization, by treatment, by all kinds of things. But one of the things I was involved in at the time was the hospice movement. And at that point, you could not access pain medication for terminally ill cancer patients. There were literally editorials that said, you can't give narcotics to cancer patients who are terminally ill, they'll get addicted. We were like, what? And it took pioneering work in the use of pain medications in terminal cancer to establish really good protocols. A simple example of it at the time was if you had a person with intractable terminal pain and you gave them, when it got to the unbearable point, you gave them just enough pain medication to relieve it to bearable, and then let it build up again until it was bearable. Right? Or you gave them self-control of titrated lower amounts to prevent pain ever getting to that level. The second group used totally much lower opiate medication. So issues of self-control, of proper diagnosis and proper treatment. The reason every culture has had some form of substance used for pain relief is that pain is very real. This is not to minimize alternatives to opiates, which are often helpful, but there are many sources of treating pain, and only through advocacy and education do we unlock the door in the midst of a time of hysteria. Okay, clients you're working with, a door that is locked or closed, how do you open?
Yeah, that one that I can think of is that in the Iraqi film was diagnosed with PTSD. I think a lot door is him himself because of the negative thinking that he has and his confidence. He didn't come and he hasn't come or show up for the last couple of appointments. And I just like when I think about what could be the treatment or how can we solve this, I just think about talk to kids himself about coming to that session.
So what we know is a variety of things. Trauma is one, psychosis is another, severe depression is another, which are things that can lock a person inside their own mind, inside their own self, and are having, as said in the call to action, knowledge about the truly effective things that can treat each of these conditions and break open the prison of the mind which a person can be locked. Someone you know who does not have access to something they need.
I can think in terms of among refugee or war trauma, one area that we tend to not think about is home ownership. They went through war so much that you practically live with the little possession that you can carry with you. When you come to this country and think of home ownership, it's a blessing for them. Because they're thinking that let's go hard, put on a day or so, you get a house. You don't think about living there for 10 years. So it's very hard. Like for them to actually own something, have a garden and something that you can actually cultivate for a long time, is unusual, unheard of for a lot of the home families. So that's when it's about that. Ownership of a home can free up their mind a lot because they actually own something, have something with them that's tangible.
It's very powerful. For refugees, there are often weeks, months, years, decades of homelessness. One of the things that comes out of the habitat piece of the 5H model. And we now have countries like Uganda, which currently has the largest number of refugees in the world, 2.2 million. We have refugees internally and externally around the world who have lacked home. Dr. Sebastian has talked about the simple moving from a tattered tent to a structure that feels more permanent. But when one reaches a country of peace, one has the hope for a place that is my own, plot of land. Now we also have a lower level of home ownership in this country than we have had in many decades. Housing costs have gone beyond what the person can afford in many of our communities. We have more renters. We have more people being evicted from rental properties and homes because of their lack of access to resources in the community. We have more people who move from one friend's place to another, the home of their own. So this inability to have a home and anything that is set up that makes it more likely that a person can find, have, and stay durably in a home is really critical.
In that, we know that as we are dealing with folks that are from chronic mental illness, the issue of homelessness is huge. And the homelessness issue in this country at times is very invisible, but thank God that there are very dedicated people that are trying to make that problem very visible. Now, here I want to give testimony to what a focused mental health approach to those that have severe mental illness and have lost homes and become homeless for years means. Here in the county, we participate in what is called the Comprehensive Community Services, or CCS program, which is duplicated in several counties across the state. And we have experience now with folks that are part of our caseload who had been homeless for 6, 8, 10 years and had given up. But because somebody in their life was persistent, talk to them and convince them to come back in, get out from the street to a home, and get the support needed, usually through a case manager, a lot through a peer support specialist, somebody with lived experience who has now come from the streets to home, and made tremendous progress. And that stabilization coming in the home setting has had an improved trajectory on stabilizing the symptoms. People are then able to better manage their medication. They are able to manage their medical, their physical, and medical needs. They are able to open up providers to come and visit. These are services that are very important to sustaining life. And so rehabilitation is possible to reverse or minimize the impact of disability, which you had referenced earlier on the high cost of disability that mental illness causes. So recovery is manageable. So thank you for mentioning that issue about home as being a barrier, but also being an incredible opportunity.
So we want to add that to one of the things we were talking about from the dialogue of the 4 countries, that one of the quote solutions to not having so many people in hospitals is to incarcerate people. The other solution is to have them be homeless, because the perceived cost of providing care, if they vanish, if individuals vanish from care, is these two places. And so very different solutions are needed for both. One, a very different approach to how we treat incarceration in this country. And the second is, in homelessness, a housing first model with really robust, comprehensive community services. Madison is right now struggling with not having gone about this well. It looked around the country and said, housing first, excellent idea. So one large complex that was built for housing first was done so that people could immediately move in without preconditions, therefore decreasing homelessness. But the services were not robust. So it became a very distressed sub-community with problems with illness and addiction and crime, and not having both components. Immediate housing, not you have to go through 10 hoops first, and robust services, social and mental health. And the failure to do that is leading Madison to go reapproach that and say, how do we do that better? Okay, I think we were here with a client you have and a door which needs unlocking.
Okay, so I actually work in an inpatient mental health setting. So like you mentioned, literally there is that locked door, but I think there's also that barrier of the unknown, especially when I'm there on the weekend and trying to explain to some of our patients that these are the channels to go through. This is who you speak to about your case. We're here to make sure that you're being taken care of while you're here, but you need to go through your social worker who may or may not be here today. And so then rather focusing on, this is what I need to do to focus on my mental health while I'm here to get better so that I can eventually leave, they're focusing on who do I need to talk to? How do I get out of here? What are the steps I need to take? So those are just the barriers there of working with the correct individuals and developing these plans so that we can have these individuals reintegrated into the community in a way that is safe, making sure that your mental illness is manageable and that you are ready to reintegrate into the community, but you're also receiving the care that you need while you're here.
So one of the dilemmas we've noted is that part of the change in psychiatric care in this country in the last 50 years was to go from long-term hospital care. So in the 3 African countries, when a person goes into the hospital, the average admission is 3 to 4 months, which it once was in this country, with long admissions being a year and longer. Some settings, such as our forensic settings at Mendoza, this is still the case, where inpatient stays are 1, 2, 3, 10 years. But many other settings, the discharge is very rapid, and the person is unprepared, and the community is unprepared. So we have people who are admitted, discharged, admitted, discharged, admitted, discharged. And that admission and discharge repetitively is not a plan of care.
So a barrier that I see for several clients is refugee clients is their family separation. And there are a lot of coping skills that we can work with, but they say repeatedly, just help me bring my husband, or just get my sons here, and then I'll be happy. And I can't be happy without them here. And so that's a huge barrier. And again, that takes, training in emotional regulation and coping skills, but also advocacy.
So the door is literally the door between 2 family members, which is the boundary of 2 countries. And that door is closed. And unless that door is open, we're currently moving in the wrong direction. We're moving from a refugee immigration policy that emphasizes family reunification to discard that as a primary reason for refugee status or immigration, and to switch to a what can you do for us today economically. What we know is that integrated families, families that are put back together, become far more productive economically. And so if the goal is that newcomers to the country are economically productive, family reunification is one of the strongest ways to do it. So work towards opening that door that is dividing families.
Sure. So before Shadow fell asleep, he actually told me that his purpose in life is to be cute and adorable. And he thinks that for some people, they don't have a purpose in life or they don't have meaning in life. And he feels like that's a locked door that we connect up into the promise.
So across the spectrum of people we see, we are concerned about suicide. And suicide is one of the statements of human behavior about lack of meaning in life. It can be a statement, there is more pain, physical or psychological, that I experience than I can handle. It may be a statement that I feel no adequate connection to anybody to feel it worthwhile to be alive because of that person being in my world. It can be a statement that I am locked inside with the demons in my head, which I cannot escape. But in all of these cases, the issue of meaning is critical. And one of the things that we talk about as a diagnostic symptom of PTSD is the lack of a sense of the future. And the sense of the future is the sense of meaning. If there is nothing of value beyond this moment, I am deprived of experiential meaning. Go back to Viktor Frankl and what was learned by people from the camps in Germany in World War II, that the survivors under the most arduous of conditions had to have a sense of meaning. She coined the notion of logotherapy, or therapy that has to do with rediscovering a sense of meaning and purpose in one's very existence. So Shadows hit the nail on the head.
So I have one client in mind, and I'd say there are two big barriers for her. One is the language barrier, and though she's been here several years, has really struggled to learn any English. And the other is a lack of safe, affordable housing. So she's in an apartment, but it's in a very unsafe neighborhood, so that really compounds her anxiety.
So I'd go back, we had early on the question of language, but we sort of shifted to the notion of language being a barrier to getting papers, being a barrier to having status, being a barrier to having safety. But I'd like to take another take on language. Interestingly, at this moment in history in this country, there is at least one side of political pressure that everyone should instantly have English and have English as the language that they can function in for all their capacities. And yet, historically in this country, a country built on immigration, every immigrant community in its first generation has clustered in communities where in a neighborhood or a church or some community gathering, a primary language of origin continues to be used, providing a sense of connection, safety, security, and belonging. Adaptation occurs over generations, so that in second and third generations, we were talking about this earlier today, the the good bad happens. First generation still speaks the family of origin language. Third generation speaks only English. The grandparent and the grandchild can't speak to each other. And the grandchild now in high school or college goes to a summer enrichment program to learn their language of origin so they feel part of the family from which they come. So part of opening this door is our coming to value languages of origin as truly valuable to family, worth maintaining, worth having, worth knowing, and valuing bilingualism or more. Not you must shift, you must lose something in order to gain something, but the enormous value that comes from being able to stand in multiple worldviews, governed by multiple languages, the richness of that human connection is much greater. I'm thinking at this point we may have run a good length of time for the webinar. So we might close that portion, have a few minutes to stretch, and then what we shift into is a difficult case conference where we talk about more confidential information that can't be done. Okay. So some closing comments from Dr. Sebastian.
Okay.
I guess for me, I wanted to talk about beliefs as how that can be locked door or unlocked door. And the origins of this concern for me is exemplified through a couple of examples that are my clinical work I have had. Those include patients who may have schizophrenia and other serious mental health conditions. The use of medication regimens would make a difference. But because they have been convinced or are not encouraged or are discouraged or are influenced by culture of faith, that any medicine is out of the option, that becomes a huge barrier. And so then it extends the suffering. That's really preventable, but it can be very, very, very debilitating. The reverse side of that, the other side of that coin is how quickly changing that belief system through encouragement, the family members coming together to say, hey, Sebastian, John, Tom, Ali, please go ahead and take the medicine. It's going to be helping you to improve your health. Literally, in a matter of days, usually in about 7 to 10 days, we are able to see a drastic improvement. The other component for me on beliefs and practice goes back to the issue of meaning, whereby if I have come to believe in myself that my life is worth it to go that next step, that is worth to be alive because of ABC, reasons to be alive, that also become saving elements that can help unlock the suffering that's normally connected to your mental illness, especially loneliness. Loneliness and the sense of the experience of not wanting to be social or completely asocial and disengaging completely. And so I look at that and I learn from our clients that as the support system expands, psychosocial system expands, the beliefs are also amplified, refined, and properly accepted through encouragement. And I find that as crucial in terms of promoting mental health as part of total health.
So part of what that's coming back to is the integrative model that Dr. Sebastian began with. It's developed as our working model in the East African conferences. Bio, you do have a body that may be healthy or physically ill. And physical health makes better mental health. And biologic treatments matter. Psychologically, we are each a person with things trapping us in our minds, in our lives, disconnecting us from others, but with strengths, resilience, resources, and self-care that are possible. Social, interactive community is essential to being healthy. Spiritual, cultural, the surround in which we live, give meaning, and the environmental, the world we're in, which sustains us. And when we, that can be from an unsafe neighborhood to temperatures that have so caused drought that there is no water, no plant life, no food. So when we are stuck with any case, it's always helpful to step back and look at each of those rings and say, which ones are we not attending to? Because if we've narrowed in on any one of these and what we're doing is not working, it's often because there are pieces in the other dimensions that we're not paying attention to. Okay. Yeah. If people want to stretch for a moment, we'll start.
Okay, so thank you for everyone joining us today, and for those who will be viewing this at a later date. Again, please visit the YouTube channel for the Wisconsin Immigrant and Refugee Mental Health Network to view this as well as our other webinars. Thank you.